Hi, everyone. This is Inga Hansen, editor of MedEsthetics magazine. Thank you so much for joining us. We are going to go ahead and get started with today's webinar. If you have any questions during the presentation, please type them into the box on the right-hand side of your screen, and we will answer them at the end of the webinar. Today, we'll be discussing how to address hyperpigmentation in patients with sensitive skin and the importance of offering non-hydroquinone-based treatment alternatives. Our presenter is dermatologist Dr. Carl Thornfeldt. Dr. Thornfeldt is a researcher, medical director of CT Derm, and the founder of Episciences, maker of the Epionce skincare line. Thank you so much for joining us, Dr. Thornfeldt.
Thank you so much, Inga. It's so great to have all of you joining us today, and it's a great pleasure for me to be able to share this science. Not only am I still a practicing dermatologist and have been for 40 years, but I also led the basic research team that resulted in the scientific foundation for the creation of the Epionce skincare line. So I'm still in the front lines on a daily basis. And so we're going to get started here on the slide presentation. So, what determines pigment is a variety of factors. Most importantly, it's a combination of 279 genes as well as environmental factors. So when people say, oh, we're going to look at the 23 key skin aging genes or the 18 genes, whatever, you have to remember that all these major skin conditions are associated with numerous gene abnormalities. So how do they know which of those key genes was the one that was responsible for pigmentation in this particular patient? Visible appearance is also due to the Fitzpatrick skin type, as well as intrinsic and extrinsic skin aging changes. So how does hyperpigmentation occur? Most commonly, it derives from radiation from the sun, especially UV, but can be also from infrared and visible light. We know hormone imbalances, disrupted skin barrier, and other environmental insults such as pollution activate inflammation in the skin. So these chronic inflammatory factors, coupled with a compromised skin barrier or an inadequate skin barrier, trigger the processes that result in the four major types of hyperpigmentation: mottled hyperpigmentation, diffuse dyschromia, melasma, and lentiginous. So more specifically, the activating factors include not just the radiation type, but also notice heat, people with any kind of autoimmune disease because of the chronic inflammation that occurs, even if you induce recurrent acute inflammation. And that's why we have to be careful with how we time our treatments that we do in office, because that can trigger hyperpigmentation. The disrupted skin barrier, the atrophic epidermis, both of those are abnormalities with many skin conditions and can all be associated with producing hyperpigmentation. And then there's other types of deposition diseases and genetic diseases. In addition, we know that pregnancy can be a factor. Addison's disease, which is a deficiency of adrenal gland function, can also be associated with it. But one of the biggest things that's raising its ugly head now is the proestrogenic pollutants from bisphenol A, which is in plastics. And that has been shown to not only trigger hyperpigmentation and chronic inflammation, as well as skin cancer and internal cancers as well, but also triggers chronic inflammation pathways and allergic inflammation pathways as well. So it can mimic a lot of different disease states. A couple of the dirty little secrets with our treatments, like hydroquinone and arbutin, both of those have been reported to produce hyperpigmentation, as does resorcinol. Now, the resorcinol monoacetate has not been reported to induce hyperpigmentation, but resorcinol in chemical peels and in other topical acne patients you have to be cautious with. There's been a lot of people recently using colloidal silver for a variety of infections, and I see that in my practice, but that can also induce a bluish discoloration called argyria. The medications that most commonly are associated with hyperpigmentation because they modulate melanocyte function, and the melanosomes include minocycline, oral contraceptives, and antimalarials, as well as other internal agents. And then The others that's often overlooked are the herbal photosensitizers. So when my son got married and honeymooned in the Caribbean, his wife started developing a rash on her hands, purple brownish rash, and turned out it was because of the interaction with the ultraviolet A light and the lime juice, which has a furocoumarin, which then activates this type of dermatitis. Tea tree oil is another one that's being used for a lot of different infections and acne and so on. The problem is it's a phototoxic agent, and so you can get hyperpigmented induction from the tea tree oil. So that's something that should never be used in sun-exposed skin. So it's a very complex process that produces the pigment synthesis. There's 14 major and 2 branch steps. 3 of those steps occur outside the melanocyte, and the rest occur within the melanocyte, which are located in the basal layer of the epidermis. Now, these different steps will produce 3 different melanins: the DHIU melanin, which is black, the DHICAU melanin, which is brown, and the pheomelanin, which is red and yellow colors. And this is a cartoon showing the pathway, obviously a very complex pathway. This is not something to memorize. The important thing is that you have the pro-inflammatory insults cause release of endothelin that will increase alpha MSH or melanotropin to induce pigment synthesis. Then the pathway is listed below there. But releasing endothelin also causes melanosome transfer, and that's why when you do certain procedures, you may get a very rapid onset of some pigmentation because of that immediate melanosome transfer. And what I mean by that is the melanosomes are the packets that the melanin is stacked in, and then those melanosomes are actually transported out to keratinocytes. And so each keratinocyte has a melanosome that protects it from the light damage. And that's the last stage, actually, which is the distribution pathway. And so it's those changes that actually affect how the melanin is distributed and has an ultimate effect in color. So the color is melanosome distribution, but also the amount of eumelanin, the amount of DHICA brown eumelanin, and the amount of pheomelanin. And that induces the color pattern. So the melanosomes begin their journey. They're in the basal layer, and then, as I said, they make the melanosomes, and then the melanosomes are come out from the melanocyte in these amoeboid arms. So one melanocyte supplies melanosomes for 36 keratinocytes. So let's look at conditions specifically. So melasma or chloasma shows dark spots and discoloration, and that's caused by overproduction of melanin and abnormal distribution of melanin. So let's talk about the hyperpigmentation treatment, because there are a lot of changes that are occurring in this particular field. Why? Because our current treatments don't work that great. And so there's been a lot of research worldwide about different ways to treat it. And so a lot of patients, or a lot of companies are claiming efficacy of hyperpigmentation, but the problem is that most of it is laboratory. So there's 150 herbs that are claimed to have lightening, whitening, brightening, and depigmenting effects in laboratory testing. The problem is the FDA has shown that the odds are that something that's proven in the test tube actually doesn't work in patients. So you really need to look at products that actually have either patents filed, or more specifically and better is, in fact, clinical trials. So there's 105 herbs that have been claimed in patents to be effective, but only 44 actually have documented open clinical trials, pilot clinical trials, or clinical trials with anecdotal reports. There's 38 of those 44 have actually been documented to have efficacy in blinded prospective controlled clinical trials. So those are the ones you want to focus on, ones that have actually been used to treat living, breathing human skin. Now, there are 27 of these herbs are commercially available in various blends of extracts, which then result in those 38 products that were studied in clinical trials. And so that's a continual changing process. Now, we don't have a single ingredient that impacts more than 3 melanin steps. That's why it's so difficult to treat and why there's frequent rebounds. So when you go back to the pathway and you could see the complexity of the pathway, it makes sense then that products are going to need to be complex and they have to manipulate multiple pathways to produce the best effect. And after we did this evaluation and realized how complex the process was, that's why I decided to take a different look. Because the standard treatments were, well, inhibit tyrosinase, which is the rate-limiting enzyme in the production of pigment slash melanin. That's one way to do it. Well, that's what hydroquinone and kojic acid and arbutin do. You could destroy pigment cells, which hydroquinone does. That's why it's outlawed in most of the developed world. But many ingredients that actually have an impact in the test tube, the problem is when you put them on living, breathing human skin, to get a high enough concentration to actually work in the abnormal cells and get it delivered to those cells, you have to break the skin barrier, which then triggers inflammation, and in the case of hyperpigmentation, often results in hyperpigmentation rebound. So when you see pictures of studies that were done 4 to 8 weeks after a treatment and they show dramatic benefit, that's fine. The problem is what happens at 3, 4, 12 months, how much rebound is there? And we know in studies that have been done with lasers, 1 year after a laser resurfacing treatment, a third of the patients have hyperpigmentation resulting from that particular treatment. So you have to be very careful with compounds that induce that. Well, those compounds include hydroquinone, arbutin, kojic acid, and vitamin C will induce that. In the original vitamin C study, 1/3 of the patients dropped out because of contact irritation. Now, many of the botanically derived ingredients, those herbal ones that I mentioned earlier, they're being added to hydroquinone to improve not only the tyrosinase inhibition, but to reduce the irritation and sensitization. Well, how about if we use products where we didn't even have to use hydroquinone, so we didn't have that activation of those problems? And so that's what our focus has been. As I mentioned, it's well known that hydroquinone, kojic acid, and arbutin, as well as vitamin C, do damage the skin barrier at high enough concentrations to produce a therapeutic effect. And so consequently then, patients are very poorly compliant. And as you know, from a topical point of view, the most important is having the patients want to use the product on a regular basis. Otherwise, they don't get good enough suppression of whatever the skin abnormality is. So our strategy was, after we understood, as I mentioned earlier, how complex the pathway is, what about if we could manipulate every one of those steps? And we could do it without producing irritation, and we could do it without blowing open the skin barrier. In addition, we wanted to be able to strengthen the skin barrier and blunt the effect of the environmental factors which trigger the rebound hyperpigmentation. And so that's what the strategy of our treatment is. And we found that because of the complexities, we needed to go to botanical extracts. And the reason we do that is because botanical extracts have numerous different biologically active compounds, all there in their environment, that are used for protection, for storage, and for function of the herb. Well, we can harness those, and by combining those that work on different pathways and taking advantage of what's called the entourage effect with herbs, where there's other molecules in there that help stability, help delivery, and help efficacy. Combining those together allows us to produce the type of products that we wanted to introduce. So our blends are different in the fact that we address every single one of those steps in the complex pathways. well, that's all great, that's nice to hear that science, but we got to show you the proof. And so we developed what's called the MelanoLyte Skin Brightening System, which consists of MelanoLyte Tx and MelanoLyte Pigment Perfecting Serum. And we did clinical trials to prove that they work in all 6 Fitzpatrick skin types. As a matter of fact, we're the first line that has actually targeted all 6 Fitzpatrick skin types specifically in our clinical trials. And we showed that not only were we effective and safer, and oftentimes better than other prescription products, but we didn't induce the irritation, and so we had minimal to no rebound at all. We did the clinical trials on the face and décolleté area. Incidentally, these products are free of hydroquinone, parabens, and sulfates, so the potential real toxins out there we don't have. Now, to show again the activation pathway, you can see why we need to have the 2 different formulations. So as we're blocking all these different pathways, the MelanoLyte Tx, you can see works on a number of these pathways. But unfortunately, because of the complexity, we didn't have, even though we spent a couple of years working on trying to design a single product, we couldn't get all the ingredients at high enough concentrations to be able to form a stable formulation that was cosmetically elegant. And so we decided to make the 2 products. The differences, the MPS, longer lasting effect. These ingredients have some reservoir effect in the skin, so they last for a longer period of time. And their molecular structure is such that they were much more difficult to deliver. And as you know, those have heard me speak before, I want to make sure that you use an ingredient so that it actually works. That means high enough concentration delivered to the target cell type to actually manipulate the cell. So the delivery system is critical, and these 2 formulas have different delivery systems so we can get that therapeutic activity of the active ingredients. And then, as I said, we've proven that they actually do work. So what are the key ingredients? Well, in the MelanoLyte Tx, we have white water lily, and that inhibits that MCIR step, the first initiation step, as well as gene expression. It's anti-inflammatory, superior to licorice, which is one of the 3 or 4 most potent anti-inflammatories. Plus, it in and of itself has lightening effect. Crithman maritimum extract is an algae extract that has a function on retinoid receptors, but it does not cause release of tumor necrosis factor alpha or produce that retinoid irritation when you start treatment. Undecylonyl phenylalanine has been shown to be more effective than arbutin and hydroquinone in reducing melanin synthesis, and it also inhibits the alpha MSH, that second step that I pointed out earlier in the activation process. And then we have some licorice extract, which this particular extract has been shown to be more effective than kojic and ascorbic acid in reducing hyperpigmentation. It does block multiple melanin synthesis steps, but in our formulation it is not systemically absorbed. In the MelanoLyte Pigment Perfection Serum consists of turmeric, a specific lipid-based extract called turmerone, which inhibits more steps of the pigmentation process than any other single active ingredient and is the second most potent anti-inflammatory agent. We also include peppermint extract, which is anti-inflammatory and antimicrobial, 2 pro-inflammatory microbes, so it helps balance the microbiome at the lesional site. The bamboo and green pea both accelerate epidermal turnover, so you get faster resolution of migrating melanosomes out superficially. And then paper mulberry, which is a less irritating analog of arbutin, which does modulate 1 step. So that's nice to have that cool story, but the question is, does it really work in clinical trials? Well, let's look at what we have and that's currently on the market, and one reason that stimulated me to start working in this arena. Well, when you look at the data for hydroquinone, the best published efficacy trial showed a 63% clearance rate. As a matter of fact, the FDA data for the phase 3 clinical trial of a 3-component system, including prescription corticosteroid, prescription retinoid, as well as hydroquinone, had only a 51% clearance rate. Yet, the published irritation rates have been up to 87%. Well, wait a minute. If chronic inflammation or irritation is one trigger for hyperpigmentation, why would you expect prolonged efficacy? Okay, so that question has been asked by a lot of prominent researchers in the arena, and how can we control that? And so that's what we wanted to do, is to prevent those rebounds by not allowing this kind of injury to occur, because after all, people want long-term results, not just clearing quickly, but they also want to have results over the long term, and they want to be using products that they enjoy using. So with this data, it was clear that we needed to focus on improving efficacy and safety. So the first clinical study, we used the MelanoLyte skin brightening system, compared it to Obagi Nuderm, which was 4% hydroquinone, tretinoin 0.05%, and ascorbic acid herbal extract combination. This is an 18-week study with Fitzpatrick skin types 1 through 3, randomized study of Caucasian, Asian, Hispanic panelists. And we did a treatment phase for 12 weeks, and then we did a 6-week regression phase to see how fast the rebound would occur. Because in my practice, I would see rebounds within 2 weeks to as long as 6 weeks in the majority of the cases, sometimes longer than that. And the investigators were board-certified dermatologists. In this clinical trial, we found that the MSBS, the MelanoLyte Skin Brightening System, was highly statistically superior in treating lentiginous and statistically superior in treating melasma compared to the Obagi Nuderm. So very important there. Highly statistically superior means if you run the trial 1,000 times, 999 times, you're going to have the same clinical result. The MSBS was equal in treating dyschromia and mottled hyperpigmentation to the Obagi product, and no significant irritation occurred with MSBS, which is really important, which I'll talk about in the safety in a minute. So here's the clinical trial results. What's important here is in the lentiginous, there was really no difference in efficacy during the first 12 weeks, but at 18 weeks, there was such a severe rebound with the Obagi Nuderm, the patients were 31% worse than when they started the clinical trial, meaning that our Epionce product was highly statistically superior in efficacy. And when we looked at melasma, particularly at the chin and cheek sites, we were statistically superior in treating melasma over the Obagi at both 12 weeks. And again, at the 18 weeks, we were still upholding the benefit without significant rebound at all, indicating that we were superior. Now, as I mentioned, the two other types of hyperpigmentation, we were comparable. But then when we went to the safety studies, we found that, unfortunately, by 4 weeks, 100% of the patients using the Obagi system were in fact inflamed, and so we had to stop the vitamin C antioxidant serum because of the irritation rate, we were statistically superior in reducing erythema in the following time points, so out at 12 weeks. However, also with scaling and dryness, the Obagi more than tripled or about tripled the severity of it, so 200% increase in worsening, and dryness and tight almost doubled. So we were, again, highly statistically superior in safety, and we had nobody that had to drop out because of any irritation. Then we did a second clinical trial using the MelanoLyte skin brightening system, compared it to a proprietary potentiated hydroquinone 4%, which I had designed the delivery system and stability system on it to make it comparable to 6 to 8% hydroquinone. And we did this in Fitzpatrick skin types 4 through 6, 4 different ethnicities. Asian Indian, East Asian, that was performed in New York by Dr. Sadik, and Black American and Latino in Los Angeles by Dr. Pearl Grimes. For this, we treated 16 weeks, and then we had an 8-week regression period, so a total of 24-week in a prospective randomized clinical trial with 49 patients. When you looked at our results, so we compared the MelanoLyte skin brightening system with the potentiated hydroquinone, and we had superior efficacy in the MASI parameter. So this is MASI is the Melasma Area and Severity Index, and so we looked at the darkness for that, and we found that 71% of the subjects improved with MSBS. So it was statistically superior to baseline at all time points, and had a trend towards statistical significant superiority to the potentiated hydroquinone at week 8. And it was numerically superior at other time points, but not statistically superior. Then when we looked at the homogeneity of the MASI, in other words, how even the pigment was, we found that there was a 66.7% reduction in color variation of each spot. In other words, our product was evening out the skin tone. So rather than producing speckled areas where you had areas of clearing around an area of hyperpigmentation, we didn't have that. We actually evened out the skin tone, indicating that we were modulating the abnormal processes within the normal melanocyte synthesis cascade for melanin. So there was no difference between these at any time point, but we were statistically superior to baseline at every single time point. But then we also used a measuring device called a mexameter, and mexameter actually measures the amount of melanin. And we found that the MSBS decreased melanin by 90.9%. And remember, as I mentioned earlier, the FDA found that a triple component of hydroquinone only reduced, had 51% clearing, and here we reduced melanin by 90.9%. So we were highly statistically superior at all time points. We were also numerically superior over MSBS over the potentiated hydroquinone at all time points as well. And here's a couple before and afters, just using our formulation. Here's one. This was a patient with an autoimmune disease, so treated for a longer period of time. And in this picture, you can also clearly see the decrease in extrinsic aging, photoaging parameters as well. And this was a patient that at 3 weeks, you can see significant improvement in reducing the hyperpigmentation. So let's talk about the regimens. So for melasma therapy, you don't want necessarily a quick response if you activate inflammation. And particularly, you have to understand that you have to distinguish between the types. Now, because I'm a referral-only dermatologist, when I see them, they've usually been on a variety of different types of therapies. And so I will use the Woods lamp to assess the depth of the pigment. And you need to be honest with patients. What the Woods lamp does, that's a UV lamp, and it will show if the pigment is superficial, there will be an increased contrast compared to when you don't have the Woods light on it. And so that means it's superficial. But I see a lot of patients in that 30 to 40% range where there's quite often not a change in that contrast, and that means there's a dermal component, usually post-inflammatory component from a whole variety of destructive procedures that were done before the skin was properly prepared. And I tell those patients it's going to take longer. It's going to usually require additional oral supplements as well as the topical regimen, but you've got to be critically as far as very, very disciplined in use of the topical regimen and the photoprotection. and we'll talk about that in a minute. Now, you may need to have hormone manipulation if you have any other types of abnormalities occurring. So, for example, facial hair, on the acne developing, or scalp hair loss, that suggests there's also other hormone abnormalities, and you need to look for that. But you also have to be acutely aware of airborne pollution, which has now been shown to be more than twice as bad as ultraviolet light in activating skin aging and skin cancer as of December 2016. So it's critically important to modulate those as well. So we've mentioned hydroquinone is the most often prescribed, but it's not for long-term use. FDA recommends it only be used for 8 weeks and then cycle off and use something else for a while, then go back on later, but they only want 8-week pulses for this. So that's one reason why the non-hydroquinone therapies are increasing in popularity, because the environmental triggers and the person's internal triggers continue to be dynamic and active even when you're off the hydroquinone. So it has been banned in Japan, Australia, European Union, and South Africa. So for treating melasma with our Epionce products, we use the Pigment Perfecting Serum nightly. We use the MelanoLyte Tx twice a day. In the morning, we use the Epionce sunscreen. The best application is 2 applications, 30 minutes apart, and you can put it on over the MelanoLyte Tx. And those are 50s or higher, but also are not photosensitizers and do not have any of the systemically absorbed sunscreen ingredients that in the last few months has now turned the FDA upside down about the whole situation about sunscreen safety. And our ingredients have none of the toxicity that's been reported with the others, like kill coral and activate other diseases. And then the intensive nourishing cream is at night, and that not only helps have a synergistic effect with the MelanoLyte Pigment Perfecting Serum, but it also rapidly improves skin barrier and produces a prolonged anti-inflammatory effect as well. So that's the regimen you use for those patients. So for the, as taken from our handbook, usually there's about an 18-week treatment phase, although depending on what I see on Woodslight, it may be as long as 38 weeks. So we have them use the cleanser, then the MelanoLyte Tx in the morning and night, the Pigment Perfecting Serum at night, the Renewal Facial product, and usually that will be like Renewal Facial light lotion or facial lotion in the morning over the MelanoLyte Tx, and then you put the sunscreen over that. And then the intensive nourishing cream at night. So after you achieve the clearance that you want, then you go into a maintenance phase, because our basic research back in the 90s showed that the hyperpigmentation is related to increased amount of activity of the receptors on the melanocyte, and so we need to suppress those. So then I go into a MelanoLyte Tx 5 nights a week and the Pigment Perfecting Serum 2 nights a week, of course using the Epionce Renewal and the sunscreen, 2 applications of sunscreen daily. Those will continue. It's also important to understand that alpha hydroxy acid or benzoyl peroxide cleansers, because they change the pH, will absolutely affect the functionality of the MelanoLyte Tx. So you want to make sure they're using the cleansers that do not adjust surface pH to a significant degree. So that's why. So that's one reason why we developed the Epionce cleansers. Now, do you need to use both MelanoLyte Tx and MelanoLyte Pigment Perfecting Serum together? If you want the best results, absolutely. But good results will work with either one used alone. And so you can get benefit with those. But as I mentioned earlier, it's also critical to be using the sunscreen and the renewals as well to protect against rebound and recurrence. Okay, now we can also use our Epionce products with hydroquinone. We showed that there's not a problem with that. We can actually prevent the hydroquinone toxicity. The quercetin that's in the intensive nourishing cream prevents the activation of the two carcinogens induced by the hydroquinone, and the anti-inflammatory components in our MSBS, as well as the intensive nourishing cream, also will block the inflammation that activates with the hydroquinone and repair the barrier. So, what about post-laser resurfacing? You can use the MelanoLyte skin brightening system immediately post-laser after you remove the numbing agent. Generally, I recommend waiting for 3 days or until the skin is reepithelialized before we start the MelanoLyte Tx on a daily basis. Using it immediately post-laser after the numbing agent does reduce that hyperpigmentation from that immediate melanosome release that occurs, as I showed you earlier in the cartoon right at the beginning. There is some pent-up melanosome reservoir effect there that can be released and produce that hyperpigmentation. Okay, in-office treatment. So what do we use in office-wise for treatments? It's been shown that the salicylic acid superficial chemical peels are better for treating hyperpigmentation of all skin types than the alpha hydroxy acid peels. Fractionated CO2 using skin types 6 settings, the Alexandrite 755, the ND-YAG 1064Q switched, the micronanosecond 600 nanometers, one that's just recently been introduced in the past year that has good data with that. The picosecond 450 and 800 nanometers are also good. And I also am pleased with the results with the IPL using the SkinTel device. So I did mention about the supplements. There are a variety of supplements that are non-prescription that have been shown to be helpful. Recently, just literally in the last 2 months, it's been shown that silymarin, the extract of milk thistle, is helpful in melasma, and then also pycnogenol. Pycnogenol is an extract of French maritime pine, particularly effective against the pollution-induced type. Niacinamide has been shown to be beneficial in certain races. The data in Caucasians is not very good for niacinamide. And then there's a couple of oral products, namely melatonin, does have some photoprotective effect, as does high concentrations of the cacao, so greater than 60% cacao has some photoprotective effect. And a product, a juice product that consists of a series of herbs has also been shown to be protective. And then finally, there's a prescription product called tranexamic acid, TRANEXAMIC, which has been shown to be helpful in difficult cases, and that is a prescription product approved for another indication. So usually not covered by insurance, but is also helpful in those patients. But the most important things to remember is it's not just the depigmenter, but it's also the barrier repair, it's also the anti-inflammatory, and the protection against further environmental insults. So the whole series of parts to produce the complete result in reducing the hyperpigmentation. Okay, we've gone through a lot of information today, and thank you so much. So now we have time for questions.
Thank you so much, Dr. Thornfeldt. We do have a number of questions that have come in. And one person was asking about during the Requiem period, are you not recommending a renewal product with the Melasma Requiem protocol?
Oh, no, yes, you do need renewal. The intensive nourishing cream is a renewal product that was also found to have two peptides in there that help deliver, that we can deliver to the sites to increase production of two key barrier abnormalities. One thing I didn't mention, that melasma has been documented to have a damaged skin barrier function, and that's one of the key characteristics with it. And by using the intensive nourishing cream, we're able to rapidly reverse that barrier damage. And then the renewal, the other renewals like renewal facial lotion in the morning over the MelanoLyte Tx does a rapid repair of the barrier and prevents the inflammation. Now, those are critical now that we found that air pollution is such a major driver here. And keep in mind, the air pollution can be in nano-sized particles and micronized particles, so billionths and millionth size. So you may not necessarily be aware of that, but you figure that in metropolitan areas, in agricultural areas, in fire seasons and so on, there's going to be a tremendous amount of airborne pollution that can also trigger it. So you absolutely need to have that barrier repair done. In studies out of Europe, the pollution damage was more than twice as bad as the ultraviolet in activating skin aging and hyperpigmentation.
And when you talked about using the treatment and the serum, someone was asking for clarification of the order of application when the patient applies each of those.
We use the MelanoLyte Tx first, and then at night we use the serum and then the Tx. Okay. So in the morning you use the Tx, and then at night you use the serum followed by the Tx.
Oh, okay. And you had mentioned niacinamide, I think, during the oral supplements. There's a question about what your thoughts are about using the niacinamide B3 topically for hyperpigmentation.
Well, it's interesting data on that, and that I am a big believer of vitamin B3 because of its anti-tumor effect. It's been shown that it will reduce the incidence of keratinocyte malignant deterioration by 23% with 3 years of use. It's also been shown to reduce lung cancer, colon cancer, prostate cancer, breast cancer as well. So I'm a big believer in the niacinamide, but when you look at critically at the data that's been generated, the clinical improvement was clearly documented in skin of color, but in the Caucasian skin, the data was actually basically no different than placebo. So there's, as far as its effect on depigmenting on Caucasians, it doesn't seem to have any significant difference. However, like I mentioned, I am a big believer in niacinamide for other skin benefits. Because it has impact in helping with some barrier function, blocks some inflammation cascades and so on, and is an important antioxidant used in the skin that has some mild anti-inflammatory effect as well. So I don't want to discourage the use of it, but it's not. The data is not great for it.
Mm-hmm. And we've actually had several people asking if they could get a list of all the oral supplements. So I did want to let everyone know real quickly that by tomorrow, this will be up on our website, MedEstheticsMag.com/webinar, and also on the MedEsthetics YouTube channel. So if you do want to go back and review any of the information or any of the slides or share them, you will be able to do that. And another question we had was, is it normal for pigmentation to darken during the treatment process?
Early on, during the first days to weeks, it may darken as the melanosomes that were pent up or have a faster transfer to the surface. That's how those exfoliating things work, is because they increase melanosome transfer. So a lot of times you get darkening early on, and that can last anywhere from a couple days to as long as about 4 weeks as those melanosomes are being extruded there. So that's not unusual.
And there's a question in terms of the application of the products again. Someone's asking how much time should patients wait after they put the lotions and serums on before they apply a sunscreen in the morning?
Okay, so for the gels and the serums and the lotions, they penetrate in very quickly. Our Epionce products, we actually did studies looking at delivery. Dermatopharmacokinetic studies is what those are called, and we found that we had delivery literally within seconds of most of the active ingredients. And so they can put them on, and then usually we'll wait 2 to 3 to 4 minutes, basically whatever it takes to get things moved around, and then get the bottles open properly to go ahead and put the sunscreen. So you don't really have to have a waiting period like you do with the retinoids, with these sunscreen ingredients. Now, keep in mind, one of the key factors, though, for sunscreen efficacy is you have to have a normal barrier function. It's been shown in a study in Los Angeles that when they took people off the street and found that 70 to 90%, depending on the race, had barrier function less than 50% of normal. They put a 33 sunscreen on them, checked them 20 minutes later like the FDA recommends, and the protection factor was only 4.5. Why? Because they don't have the ingredients, the lipids in the stratum corneum to bind and hold the sunscreen ingredients there. Well, now that we know that 5 major sunscreen ingredients kill coral, you don't want all these things being absorbed. So you want that sunscreen to stay there in the stratum corneum. That's how it actually works. So barrier function is absolutely critical for sunscreen to have its optimum effect.
And related a little bit to post-procedure and barrier function, you had talked about being able to use these products after laser skin resurfacing. And we had a couple of questions asking if these are also beneficial to be used following broadband light or non-ablative, and also if there are benefits used post-microneedling.
Okay. So the post-procedure, basically what is really important for people with hyperpigmentation is prior to doing any procedures, you want that skin to optimize its function and rebalance its inflammation pathways. And there's 7 inflammatory pathways there in the skin. And it takes about 4 weeks to rebalance those. So I always have them do a pre-treatment of using the system that we talked about for 4 weeks before we do the procedure. And then immediately after the procedure, to help reduce that immediate hyperpigmentation, they can use the MelanoLyte Tx. But generally, you need to then use the skincare regimen that's going to what we call the post-treatment kits, which cause a very rapid rejuvenation. And our Epionce renewal kit, the Essential Recovery Kit, actually has been shown to be superior to Aquaphor in speeding healing, turning off inflammation, and most importantly, after using that kit for only 4 days, at 28 days after, we were highly statistically superior in reducing wrinkles and sagging of the skin, just by using that kit and nothing else after at that 4-week period. So that's the first post-op kit that's actually been proven to reduce the photoaging parameters, including hyperpigmentation after a treatment. So the Essential Recovery Kit is critical to use immediately post. Now, as I mentioned, if it's a person with hyperpigmentation, I'll use that Essential Recovery Kit, put those products on, and then use the MelanoLyte Tx then, and then we usually wait until day 3 before we start using the MelanoLyte brightening system on a daily basis.
And are the MelanoLyte products safe for women who are pregnant?
So the problem with that particular statement, to be able to say that something is safe in pregnancy, requires a very long-term, extremely expensive study. So we look at ingredients and how we absorb. We know that none of our ingredients are absorbed systemically. We actually did work on that, and with our delivery systems where we target and keep it located in the skin, and then it's completely metabolized in the skin. But to claim that it's safe in pregnancy when you're using compounds like licorice, you need to actually have that study. So we're saying, no, don't use it during pregnancy or lactation. But the other the other components of it, you can safely use that, and there's good safety data on that. But we have actually not done the long-term study to prove safety in pregnancy. It's really the product design that gives us the confidence. But being a grandfather, I would not want to take any risk at all, and so my feeling is that we don't use the MelanoLyte Tx in pregnancy.
And we've had a couple of people who've asked what your thoughts are on the HelioCare line of oral supplements.
HelioCare is really important. It's one of my workhorses because the polypoidium leukotomus does absorb ultraviolet A, and it does have some anti-inflammatory effect. It's been shown actually in treatment of vitiligo to reduce vitiligo by 55% with 12 months of use. So I do use HelioCare a lot, and I meant to put that on my list of ingredients that I use on patients with hyperpigmentation that doesn't respond to the topical therapy as well. I think it's very effective, but there is a caution, and that is 6 weeks ago, a study showed that 70% of the generic polypoidium leukotomus brought in from particularly the Amazon region was contaminated with toxins like mercury and thallium and several other highly toxic ingredients. So you want to stay with the brand name on HelioCare, and the best is to get it from the company Ferndale because there's a lot of diversion going on, and companies are getting product and then they're putting labels on it and selling it on Amazon. And so you got to be very careful with those particular products. So, and that's similar to what we're seeing in other cosmetic as well. A study was done showing with vitamin C, 83% had no measurable vitamin C in the product, even though the cosmetic claimed they had it. Last year, a study showed that 40% of the cosmetics claiming retinol had no measurable vitamin A at all in them. And so there's a tremendous amount of fraudulent products out there in our particular segment. So that's why, in my mind, if there is not a clinical trial done with that particular line that was done by third-party investigators, you need to be very cautious about using them because the odds are that you're not going to be getting the full active ingredients. As a matter of fact, another study, Walgreens, the feds went into Walgreens 4 years ago, and 77% of the supplements had less than 50% of the active ingredients or less than 50% of the amount that they claimed on the bottle. No laws were broken, though, and 2.5% of the supplements had zero active ingredients at all, yet people were claiming them for anti-aging effect. So you have to be extremely careful, and as a physician, that's why I sell products in my practice that have actually been proven in clinical trials to be effective. So I make sure that my patients are getting bang for the buck.
Mm-hmm. That is disappointing to hear, but also, again, the importance of working with people who are reputable in the industry. And this is going to be our last question. We had a question on whether the MelanoLyte treatment and serum can be used for under-eye dark circles.
Yes, it can. We have not done a specific study on that. The dark circles under the eyes is not just a hyperpigmentation aspect. It also has to do with a redistribution of fat. It has to do with vasodilation of the veins, thinning of the vein walls. So there's a variety of factors that go into that, but using that product, the pigment perfecting serum, in conjunction with, for example, our Epionce Renewal Eye Cream, which reverses the photo damage and also causes the blood vessel strengthening. That combination should be effective for that. I recommend in my practice. I have patients that are very happy with that. We have not done a clinical study proving that, though. But it would make sense that the combination would do well. As far as with the MelanoLyte Tx, I would only use the MelanoLyte Tx once a day on the eyelids, though. And the way I use the gels on the eyelids, because the skin barrier is so thin, is I put on like the Renewal Calming Cream first, and then put the MelanoLyte Tx over the top of that. And then at night, I would just use the Renewal eye cream, and followed by the pigment perfecting serum.
Great. And thank you so much, Dr. Thornfeldt, for joining us and for sharing all this great information.
Great. Well, thank you so much for taking the time, and great questions there. And any other questions, you can reach us at Epionce.com. So thank you again so much for taking the time and allowing me to share with you some exciting things in the realm of hyperpigmentation treatment.
Great, and thank you all for joining us.